You're mute, people. Okay, I'll go. So I was quite fascinated by the six prognostic parameters that Patricia you presented, and also the scoring system, and that reminded me of a couple of studies from Harvard and Temple universities where they are looking at neutrophil migration profiles as a prognostic factor, and it has been shown that the neutrophil migration impairment occurs and it correlates with the severity of sepsis. So what are your thoughts about it, and do you think that it could serve as a prognostic factor one day as a functional response of immune cells?
Yes, definitely. I think the reason we picked the 6 indicators is that these were indicators that the sites could easily measure, because not all of the sites had research labs attached to them. So I guess if you wanted to look at neutrophil migration, I'm not sure the time frame of that, but if it requires the neutrophils to be isolated, my sense is that that probably would be an assay that would require several hours versus a point of care device where these routine clinical parameters or indicators could be very easily measured at the bedside.
Yeah, I think I can elaborate on that a little bit. They are using these microfluidic chips for the migration assays and only a drop of blood from the finger prick. So it could be a point of care bedside assay.
Right. And I guess you would need to just have whole blood then, right? You don't even need to process it.
Yeah.
That's interesting.
I think everyone, thanks for your talk. I have a few questions for everyone, actually. So when I talk to these, specifically for Patricia, I think when I talk to these critical care specialists, they tell you that the biggest trick when a sepsis patient is in ICU is to maintain glucose levels. So but they don't provide me any explanation why. And regarding the question from Ionis, that struck me that actually maybe the metabolism has to play a role which has never been investigated. Do you think, or I don't understand, but they said that it's a very thin tightrope. You have to maintain the glucose level.
The challenge with mice is that unlike in humans that develop hyperglycemia, in mice it's actually the opposite. So we see a rapid drop in blood glucose within 4 hours of inducing sepsis. So, trying to maintain blood glucose in the mice, we've given IP injections of dextrose, for example, to see if that helps to improve survival. But because it's the opposite of humans, I'm not really sure how we would study that. And in humans, maybe some of the clinicians could comment, but I'm not aware of maintaining, tight blood glucose as something that is standard of care.
I'm a pediatrician, so things are different for us because our patients tend to be healthier at baseline, but a lot of times these kids will end up on steroids. And in that context, often we have glucose control becoming an issue, but at least in the context of pediatric sepsis, outside of the context of steroid treatment, glucose control isn't a huge component of what we use. Granted, I'm a hematologist, not an intensivist, but that's been my experience.
Great. Thank you.
I have another question regarding NETs to both Patricia and Candice. So DNase has been around for a while, and I know has been tried. It's also FDA approved for cystic fibrosis. So why not something like neutrophil elastase, which has so many inhibitors in preparation? Why that has not been? Is there the issue with it, or something which is more therapeutically targetable? And I know people have the deficiency also, like alpha-1 antitrypsin. Is there some interest in that, or there are issues with testing something like that in patients, or at least in mice models?
I think danirixin and laparixin, that kind of class of molecules, has been developed as a neutrophil elastase inhibitor and are used in the treatment of COPD. Yeah. I haven't seen them used typically in the treatment of sepsis, but that class of molecules certainly does exist.
Okay. And I have one question for you, Candace. So from where this PF4 comes, is it platelet derived, platelet release that, or it's in the circulation, or it comes from the endothelium? Where do you think this PF4 comes from?
Yeah, so I think platelet factor 4 is primarily made by megakaryocytes and then is loaded into the platelet alpha granules. And so platelets are going to do the bulk of the work of sort of moving PF4 around the circulation. One of the questions in the chat was, hey, doesn't PF4 get elevated in the plasma of septic patients? And absolutely, you get platelet activation, you get degranulation, and there's been a few studies, I think Patricia's done some work on this, where we do see that there's elevated platelet factor 4 in both murine sepsis as well as human sepsis. But PF4 is a very promiscuous molecule in that it loves to bind to negatively charged compounds. And so it doesn't stay in the circulation for all that long because it will bind to glycosaminoglycans in the glycocalyx on top of the endothelium or GAGs as well on top of circulating cells. And so if you want to get your highest local concentrations of PF4, I think the best way to do it is through kind of a platelet. And so my hypothesis is that NETs, since they do such a great job of binding platelets, that you probably, when you're not severely thrombocytopenic, you probably get a pretty decent delivery of platelet factor 4 to your NETs in the context.
Okay.
So there's a question in the chat that I'll take. It's sort of directed at Patricia, but it has tissue factor in. So it's asking about whether the tissue factor that's sort of derived from a virally infected cell will be active. Well, we know hemorrhagic fever viruses induce tissue factor in monocytes, and that causes DIC. So there's a direct activation of the monocyte in those cases. The delivery and packaging of the tissue factor from the virally infected cells, I think, is more debatable exactly how that's contributing to DIC, but there is direct activation of monocytes with hemorrhagic fever viruses.
I just had one quick follow-up comment to Nigel's question in regards to all the toxic molecules that are released when you dismantle the scaffold that is DNA. There are host acute phase proteins such as C-reactive protein that can neutralize.
And others where they have shown that if they give DNAs, the liver injury was not prevented. They give neutralized histones, it was not prevented. And finally,
Elastates in the histones.
yeah. And Nigel, I have a question for everyone's knowledge, I think, so why you think TFPI failed in sepsis? Do you have any input on that? I've heard a lot about this, when you go to sepsis talk, they talk about this TFPI clinical trials, but some people still believe that it was not the proper trial.
Patricia's talk. I think we could do a much better job if we started tomorrow designing a new trial. And certainly what's fascinating to me is that soluble thrombomodulin is only effective in patients with a DIC. It's completely ineffective in patients without DIC. So there's a good sort of indication that you've got to have DIC before you put an anticoagulant. If you give it to the whole population, it fails.
Okay.
And that's what soluble thrombomodulin did in a septic patient population. It failed.
Okay,
Patricia, do they have any way of identifying patients who are developing DIC versus not DIC in clinic, or they just say this is sepsis?
I mean, they do routinely collect the INR, D-dimer, and fibrinogen, so it can be calculated. within our cohort of 400 ICU patients with sepsis, roughly 1/3 of them did have DIC. And the challenge is to identify biomarkers that predict DIC. So we found that antithrombin consumption and also protein C consumption were useful to predict the pre-DIC state. But I don't know if clinically DIC status changes, treatment strategies.
Thank you very much, and I think I will have one more question to both Nigel and Chin-Yu. So what about the role for endothelial tissue factor? Is it important, or it's only important, or it's all how that plays in context?
Well, I can tell you, if you put an antibody against tissue factor in the mouse models, you block about 80 to 85% of the activation of coagulation. If you selectively target the hemopoietic cell population, you block about 50%. So we can conclude that the monocytes are probably contributing about 50%. There's other 50% coming from another source, which we believe is increased vascular permeability, not the endothelial cells. So when we did the genetic deletion of tissue factor in the mice, we actually didn't see any effect on thrombin antithrombin complexes, and people are a little upset about us because they spent years working on endothelial cell tissue factor. Well, the data is the data. It's not saying it's not doing anything. It's not doing anything that we can detect, and I think there's far higher levels of tissue factor around the vasculature, and if you increase vascular permeability, what are you going to do? You're going to expose that tissue factor, and that's going to lead to an activation. So I think if you want to completely block the tissue factor activation of coagulation, you'd have to block the monocyte, and you'd have to protect the vascular permeability leak, using molecules such as APC, or this cytoprotective APC would be a candidate to try and prevent the vascular permeability changes.
And I think there is one question for Chin-Yu, Dr. Lee, on the chat box, and I think Mr. You can read that, but I have one more question. So for Nigel, so extracellular vesicles that express tissue factor, they have to be exclusively derived from monocytes, because correct me, platelets don't express tissue factor, right?
In our view, platelets don't express tissue factor. It's a little controversial, but in our view, they don't express tissue factor. But the study by Vijay Rao showed that if he damaged the vasculature, he got extravascular tissue factor positive vesicles coming out, right? So all cells can release tissue factor if they express it on the surface. So, when we look at that EV tissue factor, we can't tell you where it's from. We just know that it's elevated in the circulation. A lot of it's probably coming from monocytes, but we can't say it's exclusively from the monocyte.
Yeah, in our model, we found that the tissue factor is highly expressed on the monocyte and macrophages. I think in the endothelial cells, they might need induction, in real sepsis, right? The tissue factor from endothelial cells can also contribute to the coagulation.
I mean, Tom Drake did studies many years ago with baboons, and he looked very, very carefully for tissue factor on endothelial cells in septic baboons, and really couldn't find it apart from a couple of sources. And then the difficulty is, if you see a positive endothelial cell, you don't know whether the endothelial cell made it or whether the vesicle from a monocyte got sort of bound to that, and that caused the signal being elevated in the endothelial cell.
I think there is a question. Go ahead. There is a question for you, Chin-Yu.
I think about the why failure of anticoagulation in sepsis. I think time is a critical issue, and our diagnosis of DIC is based on the scoring system. I think best timing for intervention for coagulation, I think, is at early stage, and at that time, those patients may not reach this DIC criteria.
So from all of your talk, one thing I understood, you all can correct me, that the late stage is the more inflammatory stage, where the coagulation is driven by primarily inflammation, and that's when.
No, I don't agree with that statement. I think the early phase is inflammation and coagulation. and the later stage is more of a complement. So that was clearly coming out of the baboon studies, as there was 2 phases. But inflammation goes up at very, very rapidly. In the mouse model, TNF is up by 1 hour. The other inflammatory mediator is 3 to 4 hours, and then they're elevated. So the first phase is coagulation and inflammation, and I don't think they're as closely connected as everybody would like them to be connected. I think they're 2 parallel pathways getting activated, and there's minimal crosstalk, and complement goes up independently as well.
Because like Patricia, I remember during COVID, there were these IL-6 receptor trials, and there also they found the same thing, that they were affected more at the later stage. Am I right? Correct? No?
Yes.
Okay,
And I wonder if that's because I really don't know the mechanism. Intuitively, it doesn't really make sense, but maybe having IL-6 neutralized too early is harmful, because you do need an inflammatory response to fight the infection in the first place.
And I have a last question for this, and then to Jen, So where IL-1, so when inflammasome activates, IL-1 beta is also released. So where that fits in the coagulopathy, inflammasome-driven coagulopathy?
Excuse me. So what's the question?
So I'm saying that, just wondering, when the inflammasome activation is classically associated with IL-1 beta release, which can bind to IL-1 receptor and promote thrombo-inflammation. So in the pyroptosis-driven coagulation pathway, how does IL-1 beta contributes? Is it known that how that drives fibrin formation? Because I didn't see that in the interleukin-1 beta.
Yeah, we tested this inflammation, the cytokines in the coagulation following inflammation activation, and we found that interleukin-1 beta and interleukin-18 actually do not contribute to coagulation. So mainly our conclusion is tissue factor released from those particle cells, parototic cells.
So Ben Liu's paper confirms that, because he took the IL-1 receptor in knockout mice and looked at the effect on the coagulopathy, and there was no effect at all. So there's not a sort of positive feedback loop going through IL-1 beta.
Yeah, I think there is a question for both of you. I don't know if we have time or not, and that but that the IL-1 beta activate monocytes to release tissue factor.
In our view, no. The only thing we found to induce tissue factor in monocytes is LPS. There are sort of some sporadic, very high dose cytokine studies with monocytes, which you always are concerned about LPS contamination of the cytokine you're putting on. But in our hands, we haven't seen any IL-1 beta inducing tissue factor in monocytes.
Okay, I think I'm here using the break. So Nitin, shall we go on the break?
Yes, let's take a break, and I think according to the agenda, we will be back at 2:15, I guess.
Thanks to everyone. Yeah. Really wonderful talk.
Thank you.
I'm sure everybody learned a lot,
Yeah.
Thank you.